So for commissioners and Rick Cronick, who are here with us, if you could go ahead and unmute yourselves, and then members of the public, you are here obviously to listen in, and we appreciate you doing so. But just for purposes of discussion, we now have the commissioners in the breakout room able to unmute themselves. So should we just have a quick hello from commissioners who are here with us?
Hello.
Hello, hello.
Hello.
Good to see you. All right, I'm going to go ahead and share my screen so we can see the notes that I will try to take. And I apologize in advance for typos, but here we go. So Rick, would you like to kick us off?
Sure. Great to see everybody. And it's useful to have this list here because I think otherwise the commissioners don't know who else is in the room, but here's the list. We want to spend about 10 minutes on each of these two questions. I think we're small enough a group that rather than using the raise hand features, I'll sort of start the conversation and people should jump in, and if anyone is silent, and we're mostly not a silent group, I'll try to I'll call on you. But let's start with asking for a volunteer to report back out to the larger group when we're done. Again, Karen will be taking notes, so you'll have a sort of document in front of you, but I would ask for someone who would raise his or her hand for reporting back out.
Right, just shout out to us. You'll have these notes in front of you on the screen. A brave soul from our breakout group.
You're not usually a shy group.
I'm waiting for somebody else to say yes, because I don't.
Oh, I think that sounds like you, Don.
That's a volunteer. Thank you, Don.
Right. Thank you,
Wonderful.
Don.
We knew we could count on you.
Yeah.
So, yeah. Let's start then with this first question of how unified financing can be designed to try to reduce disparities and increase equity. And so to say, sort of 20 seconds, as I said earlier, unified financing in and of itself will at least will help quite a bit here, but isn't going to be enough. I think we all know that. And I wonder what, how you would respond to, what are the features of unified financing, either in design or in accountability mechanisms that will really get us to the probably most important thing that needs to change.
This is Rupa. Can you all hear me?
Yes.
Yes.
Yeah, I think that I have a two-tiered thing. One hallmark is to get rid of private insurance. So the three components of deductibles, copays, and cost sharing create just an imbalance of financial stress predominantly on people of color. So the last two commission meetings, we're talking all about people of color and disparities and disparities and disparities. And I feel sad that we're not focusing our time on really moving forward with giving the key points to a system that can help our legislators. So eliminating health insurance, moving to a single payer system that does not have intermediaries, that is just the state and then the providers. The second part I would say in terms of financing is to abolish those industries that are making people of color sick. That includes policing, so defunding the police at a rate that would actually impact healthcare, lowering trauma rates in communities that are being terrorized by police throughout California, abolishing industries that are chronically polluting the air. For example, in East Oakland, where I live, the ABNI foundry is just polluting the air in the midst of a pandemic where we now know that chronic levels of air pollution lead to higher fatality rates. So these are, two ways of designing a system that will have within it just the very hallmarks of stop making people of color sick and stop creating financial penalties that make healthcare impossible for our people.
Mm-hmm.
Thank you, Dr. Maria.
Thank you. Other thoughts on this?
Yes, Richard.
This is Richard Pan.
Yes.
I mean, I think one of the things we have to think about is to what degree do we insulate the financing from politics? So don't forget, Donald Trump is president of the United States. So, you know, you have to think about who will be in the elected leadership. I mean, I'm an elected official, but that makes, perhaps I'm just a little more sensitive there to who will be. So the question is to what degree do we insulate the funding and the distribution of the funds from politics? You know, you probably want some exposure, but the question is how much? Because as I said, Supreme Court just ruled that birth control is not something that employers, I mean, you just have to keep in mind, you're not going to have the political leadership that you want, you're going to have the political leadership that you have. And so that's why we insulate various institutions from politics, right? We have you know, think about a Federal Reserve on a financial side, right? We've insulated the University of California. We can argue about, you know, as an academic institution at the state level. So I think that's one. The other question is, how do we decide how much money is the right amount of money for our healthcare system? So if you have a, you know, when you say unified financing, how do we decide how much is the right amount? So for example, we have a Medi-Cal system, which is, by the way, federal and state funded. And we can look at the access issues because of poor payment levels, right? So that's, and that amount of reimbursement is, how is it decided? Well, some of it's decided by what our revenue is based on our existing tax structure, right? So, and one can argue, is that tax structure the right tax structure or not? So there is an issue about, you know, what is the right amount? I will point out, we used to have, as an approach, we used to have a high risk pool, and it was never funded. We never had the political will to fund it at the level it needed to be funded at. In fact, people died waiting to get covered by that pool. So the question is, can we create, you know, how do we decide what's the right amount, and how do we build the political will to actually fund it adequately? Otherwise, we could have a chronically underfunded system. Because after all, said half of the people only spend 3.5% of the healthcare dollar. So you have to convince them to put in more money than they would expect to spend. And you only need 50% plus one to elect somebody. So we have to keep that in mind. That's back to the political insulation. And then how do you distribute those funds, right? How is that, so how are those, whatever funds we accumulate, how do we distribute those? Is that going to be distributed through a political process, or is it going to be distributed through some other mechanisms that may be more insulated from a, you know, it's based more on need and demand versus, and depends on how you want to define demand, but versus a politicized process. And again, this is as someone who's in politics, you know, just like we have to keep that in mind. So we have a pot of money. How do we decide, what kind of mechanisms we put in place to distribute it versus we have, you know, bodies of different people deciding, and how do those, you know, and how do those bodies make those decisions as well? So I think that's something you have to think about. So that then comes to, well, what structures do you put in place that better empowers, you know, different communities, particularly, you know, communities of color, more disadvantaged communities who generally will be in any political system, just be really honest, less enfranchised than more, you know, wealthy communities. It's just really hard to build a system where that doesn't happen over time. So oftentimes mechanisms that aren't dependent on political influence or level of influence are oftentimes, well, not entirely equitable, at least perhaps can be more equitable than systems which are dependent on, you know, a body of wise men making that decision, because who decides who's wise?
Thank you, Senator
that's something
Pan.
we have to think about as well.
Thank you.
Yeah.
I think this is a good point, maybe for me to jump in.
Great.
That was an excellent presentation, and I'm going to start from the pot of money. So I think that's a good metaphor. We have a big pot, and Rick has told us where the vegetables come from that go into the stew. They come from Medicare, Medi-Cal, private insurance, out-of-pocket payments, you name it. And that's how it's financed. I want to remind everybody that financing means where the money actually came from. So that Medicare money comes from Medicare, but it actually comes from the taxes we pay to the Medicare program. And so a certain set of the population pays for the Medicare program, and 30% of the money for the Medi-Cal program comes from the general fund, comes from taxes. So even though I think Rick is exactly right, that's what the legislature meant, I think at some point you need to think through where the money came from that went into those vegetables. Where were they grown? Where were the vegetables grown?
Yeah.
Vegetables were grown different in the Medicare program, the Medi-Cal program, private insurance. It all comes from different plots of land and different people. The reason I mention that is as soon as you try to blend them into the stew, you're going to find out that that particular group that produced those vegetables is going to be unhappy about that. And you have to somehow or another win them over. Now you got the money in the pot. And I think the worst way of spending that money in the pot is to keep the current fee-for-service system. And there's a lot of reasons for that that most people know. You can't integrate care there. It's a system that leads to overtreatment, waste of resources down the line. And it's something that basically is going out of business in the rest of the world. And even in the United States, you know, we have more people in Medicare Advantage. I could go on and on about that. The growth of managed care in various states. You know, a third of the population is already in some kind of capitated plan, as high as 50%, and you do the numbers on and on. So you got the pot and you want to distribute it. You don't want to distribute it using fee for service. You want to distribute it in a way that makes sense. And the next question is, who do you give it to? You're assuming, or somebody is assuming, we're giving it to the providers. I'm not so sure. I'd like to leave that as an open question. You could think of that pot of money going to some other group in a community, which could include providers, but other people. And it could be done down at the community level, counties, or whatever level we want to think about. And it would be based on the population they have. Now, if you go down that structure, and that's only one possible structure, you could then deal with this issue of disparities, because to allocate that money, what countries do in Europe, like the UK that Rick referred to, is they distribute monies down to communities, and lots of other countries have the same formula move, like Spain and others I can mention, based on a capitated, risk-based capitated formula. So they look at things like the poverty rate in the area, look at the
Richard, you can, you know,
they look at the equity. And so I think that's a structure that could possibly be used to solve or address some of the questions you posed.
Thank you. You know, I'm sensitive that you and I think, are the only academics in this group. And
Oh, I am as well.
oh, I'm sorry. So sorry. Well, then Rupert modeled well. Yeah, we don't have much time. But at the end, and I'd ask.
Can I just respond, sorry, to what, just very briefly. When we looked at the health impacts of the tobacco industry, probably the single best gain we've made in California is the tobacco ban. We did not care about bringing the tobacco industry to the table to talk about the tobacco health ban. We did what was good for the California people. I'm just saying that our current system is driving the inequities that we're seeing. Our current financing system of healthcare, private insurance, is driving these inequities. So if we want to have a different outcome, we actually have to create another system. And that system cannot be created with bringing those industry folks to the table to tell us how to do it, because they have created the problem. So I'm just, like, as a point of process, I just think it's important to just recognize that we don't have to bring those voices to the table.
No one has talked about bringing those voices to the table, but Janice and Bob Ross.
Sure, I can go next, just fine. And I think if we're looking at design elements and trying to reduce disparities and increase equity, we can make a list of, 15, 20 things and talk about each of them for 2 hours. So this is a format that doesn't obviously lend itself to that. So just to bring up an issue that hasn't been raised yet, certainly the design elements that are important in terms of making sure that people, that there's equity and that we're reducing disparities include what services would be covered and the cost sharing in terms of accessing the services, and access to preventative care, and having a situation, when people I've worked with who go to a particular community clinic tell me that it's the best healthcare they've ever received, and I ask why, it's because they're getting health education. It's not strictly medical services with a particular CPT code. They're getting, full care as a human being in terms of the education they need about healthcare, in terms of talking about the things that affect their lives, in terms of the social determinants of health. So incorporating those things into the healthcare system, I think, is very important. And then obviously it's just common sense that as we create the system, we need to make sure that cost sharing is not a barrier to care the way it is today. And that doesn't necessarily mean that each visit is free when you go in, but it certainly needs to be constructed in a way where it's not a barrier to care for anyone.
Yeah, thank you.
Thank you.
We have about 6 minutes left.
Can I jump in briefly?
Yes, so I was going to ask
Ross.
Bob and you
Bob,
and John, as you jump in, maybe both on the first, and this will probably be your only chance for the second question as well.
Yeah, so first of all, I'm just thrilled that we're actually beginning this conversation with an equity lens and an equity frame. I couldn't be more pleased about that. Secondly, I just want to put up something that hasn't specifically been mentioned, but it's been alluded to, and that is the health workforce. We've got to think about the health workforce as it currently stands, and the workforce we're going to need in the next 10 years. Workforce that should come from increasingly from diverse and vulnerable communities, that should reflect the diversity and cultural needs of the state. And we've got, baby boomer population in the workforce that's retiring now and about to retire. So I just want to make sure that we don't lose the importance of the workforce, health workforce. And I think it should be considered part of economic development for this state. These are good jobs. They're ladder jobs. As a general rule, they pay a livable wage, not in all cases. So I just wanted to put the workforce in there. And we may not have time to answer this as a question, and maybe we can get back to it later. Rick, I really appreciated your presentation. I find the mention of the issues of intermediaries a bit murky. It sounds like it's code for something, and I'm trying to figure out, some folks I'm watching on the chat have a really negative reaction to the issue of intermediaries. So I hope we can decode and demurk what we mean by intermediaries, maybe with some concrete illustrations, maybe an illustration of what a bad intermediary would be and what a positive, meaningful health equity promoting intermediary might be. So I wish we could figure out a way to unpack that a little bit.
Good point.
Thank you, Rick.
Yeah, thank you, Bob. Yeah.
Don, you're on mute. Don, you're muted.
I just was off mute and muted myself. I was going to say, example of an intermediate. So when you look at the European systems, as you know, some are built on an insurance model, some are single payer. Britain, for example, and the Netherlands, when you look at outcomes, very similar. And the reason is that they heavily regulate the insurers, but that's an example of a system with an intermediary. It's an administrator or an insurer who is third party to the government, essentially, and those countries regulate those intermediaries much more strictly than they do in the United States. Switzerland is another example that has a system that works through intermediaries. So the question is whether is whether you have folks like that are part of it, or you run everything straight out of the government, essentially. But so two additions. I get that right, Rick?
Yeah.
Yeah.
So,
But I would add only that I think, Richard Scheffler suggested another kind of intermediary.
fair, yeah. There are lots of different types of intermediaries. Yeah. Two additions. One is, if you're going to have equity, just a baseline is you have to have uniform benefits. So, out the United States, and the difference in what you get by way of healthcare when you work for fast food and have a bare minimum.
You froze, Don. Oh, shoot. Don, if you can hear us, you might want to turn off your video, your camera, because you're frozen. We've lost your audio.
And it might be also that we should solicit another volunteer in case Don
Yeah.
can't get back. We have a plan B.
Yes.
Anybody else want to report out? Or willing to report out? Bob? Can I finger you?
I may have heard from everybody, at least.
Or Janice?
First question.
Yeah, Janice, are you willing to report out for us if Don can't get back?
Oh, sure.
Thank you.
Thank you.
So I think we are going to get a couple of, I'm seeing we might get a couple of minutes to delay before we go back. So I would love to just power through. Let's run through very quick, everyone, like 20 seconds. How could we tell if high quality care was being equitably delivered? What outcomes and indicators should we watch for whom? Love to hear ideas. To unmute.
Well, on the top, you see, you basically don't have disparities between people with different socioeconomic classes, races, and so forth. I mean, obviously there's a lot of operational stuff underneath there, but that's the top line cut, right?
Mm-hmm.
Disparities in what, Dr. Pan?
Well, I guess in health outcomes, you can go all the way from life expectancy, infant mortality, to more specific, measures. But I think there's, I said, that's just the top cut. That's not, we can delve into more of some of the process forth that leads to that.
Thank you.
Yeah.
We could also be seeing more people coming to care, so we could analyze and look at who's coming to care, who's accessing care, what demographic they're coming from, and geographic location as well.
Mm-hmm.
Although I would probably frame that as the right amount of people. Sometimes we say more, that's not necessarily a good thing. Sometimes not. There are people who are not enough. They need to be more.
Well, I'll throw in something. I think that one of the things missing in the measure of quality of care is we have a lot of these metrics, and we have associations and the like that give stars and measure them and all of that. But I think a key element in medicine that's missing is, are people getting the right care?
Yeah.
Are they getting the right services? They may be terrific when they get them. They may be high quality, but they may in fact be the wrong service. So I think that's something that we need to talk about. And they may be getting it at the wrong place. They may be getting it at the most expensive place, or at a place that doesn't make any sense. So I think that dealing with that issue of, are they getting the right services for the treatment they need at the right place, is a good measure and a somewhat different way of thinking about quality, rather than the star system, which I think is useful but incomplete.
I agree with you, and to advance that idea, I would also say patient satisfaction. So are people feeling like are they feeling like they're getting the right care?
Mm-hmm.
Access to care, including, getting appointments in a timely fashion is key to measure. I think outcomes and prevention of chronic conditions that are preventable is important. I also think that, back to the geography idea, I think that we need to make sure that care is available in locations, whether you need regardless of your income or whether you're in a rural community. If you have to drive an hour to get to a location for COVID-19 testing, that's not accessible to people who don't have a car or who, work during the hours that they need to be driving that far to go there, or to folks who can't sit in a car to take their test, which is often required because they don't have a car. So, just making sure that there aren't barriers in those regards as well.
And I mean, all that seems excellent suggestions. And the question I would ask, it's really going back to the first question, and we probably don't have time to answer it, but we'll kind of come back to this, is these measurements get done. So imagine these measurements get done, and we find out, surprise, that people in Southeast San Diego have less access than people in La Jolla. What then? What happens to change that? And certainly having, no co-pays and everybody getting paid the same will in and of itself make some progress, but isn't going to be sufficient to change that. And
no, I think that goes to a deeper issue of land reform and taxing the rich to redistribute wealth. So I think that those are like deeper, bigger questions that will have to be addressed on a more systemic level.
Well, there's also the issue of, you may say, oh, the people in La Jolla, they're wealthy and they probably got better care, and they may have, but maybe they may be overusing the care. And so it may not be La Jolla, it may not be actually what you want.
Oh, I think I just got